Yeah, it's done. So how to do the screen sharing?
Same
My-
again, sir. Go to the more option. There is a share button down below with an arrow mark. Up arrow key. So down the screen, there are options: participant, chat, react, and share.
Participants, yeah.
So just
Okay.
share.
Okay.
Yes, sir.
Okay, good. Okay. So, okay. Good evening, everybody. So, I will be talking about the breast cancer, the basics about breast cancer. So, it takes around 45 minutes. So, I will be talking about the etiology, what are the causes, what are the risk factors, what are the signs and symptoms, what investigations are to be done, how is the treatment, and how can we prevent, and the screening. These are the things which I will be talking about. So, first of all, what is cancer, or the layman's terminology for cancer? Uh, Cancer means malignant tumor. So carcinoma, oma any means it is a tumor. Carcinoma means it is a tumor of epithelial origin. So the literal meaning of cancer is crab. So just as a crab stubbornly adherents to any part, the cancer cells also stubbornly adherent to a part from where they take origin. So carcinoma is a scientific terminology for cancer. So breast cancer. Where does this breast cancer arise from? So breast cancer arises from the breast consists of the adipose tissue and the lobules of breast glands and the ducts. So the breast carcinoma will arise from the epithelial cells of the duct or from the epithelial cells of the lobules. So the most common carcinoma arises from the ductal, if this is a duct. So cancer usually arises from the 70% of the cancers. They arise from the epithelial cells of the ductal lining. So it is known as a ductal carcinoma. So when it is limited to the duct, it is called ductal carcinoma in situ. When it passes beyond the basement membrane and it passes into the adjacent tissue, when there is a breach in the basement membrane and the cancer cells pass through the basement membrane into the adjacent.
Sir, sorry to stop you.
Yeah,
You need to explain what is in situ.
In situ. In situ means the cancer is confined to the lumen. It has not passed beyond the basement membrane. The carcinoma is limited to the within the duct itself. It is there. Then it is called in situ. In situ means it has not passed beyond the basement membrane. It is only filling the lumen of the duct. Then that is called in situ. When there is a breach or when there is a break in the basement membrane, and when the tumor cells pass beyond the basement membrane into the adjacent tissue, it is called invasive ductal carcinoma. So in situ means it is confined to the ductal epithelium only. Within the duct, it is called ductal carcinoma in situ. When it passes beyond the duct into the adjacent tissue, it is called invasive carcinoma. The most common carcinoma is invasive ductal carcinoma. So what is the cause of this cancer? The cause of the breast cancer is not completely known. It is incompletely understood. So genetic factors, genetic mutation, the cause for any cancer is mutation. Mutation can occur in among the 4 genes. These genes are oncogenes, the tumor suppressor genes, the DNA repair genes, and the apoptosis genes. If there is a mutation in any of these 4 genes, then cancer will develop. So oncogenes are the genes which cause cancer. So they are activation of the oncogenes will lead to cancer. So tumor suppressor genes, these tumor suppressor genes, they will apply brakes to the cell cycle. The cell cycle is going on. So when the tumor suppressor genes are inactivated, normally the tumor suppressor genes, they apply brakes to the cell cycle. But when there is inactivation of the tumor suppressor genes, there is a failure of the brakes and the cells continue to divide. So then there is a tumor formation. So the DNA repair genes, the third one is the DNA repair genes. When there is mutation in the DNA repair genes, then also normally whenever there is an injury, whenever there is a mutation, the DNA repair genes will try to repair the defect and save the cell. But when there is mutation in the DNA repair genes itself, then there is a more development of oncogenes and tumor suppressors and suppressor genes, and there is development of cancer. Apoptosis genes. Apoptosis means programmed cell death. So when there is a mutation in the apoptosis also, there is no cell death and there is a formation of a tumor. So mutation in any of the genes, the oncogenes, tumor suppressor genes, any of the genes, the most common cause of cancer in the breast carcinoma is mutation in the BRCA1, BRCA2. These are the tumor suppressor genes. So next one is a hormonal influence. So endogenous estrogen, or more accurately, a hormonal imbalance has a significant role in breast carcinoma. So early puberty before 11 years, if there is a puberty, early menarche or late menopause, when there is a menopause very late. So long reproductive life is a risk factor for breast carcinoma. Nulliparity, not giving birth to children, that is a risk factor for breast carcinoma. So when the childbirth is very much delayed, normally 21 years is the best time. But nowadays, the first childbirth is delayed. If there is a 35 years or so, then there is a all these things will result in increased exposure of estrogen, unopposed estrogen. Estrogen opposition is progesterone. So all these things will lead to unopposed estrogen exposure, and there is an increased risk of breast carcinoma. Environmental factors. So in United States, there is an increased incidence of breast carcinoma when compared to Japan. So when these Japan residents have gone to United States, the states which are prevailing in United States also occurred in Japanese individuals. So the main reason for this is diet or the reproductive pattern or the nursing habits which are prevailing over the United States. That is, the environmental factors also play a role in the breast carcinoma. So these are the main reasons which are responsible for the carcinoma breast. So this is a clinical picture of invasive carcinoma of the breast. There is ulceration of the breast. There is, even in the axilla, we can see an ulcerated lesion. This is a clinical picture of the breast carcinoma. So this is what the pathologist will see. So we will get the mastectomy specimens. Basically, I'm a pathologist. So here you can see some irregular gray white lesion over there. This is a lumpectomy specimen. Lumpectomy specimen is showing an irregular gray white area. This is the actual carcinoma or the cancer. This is having infiltrating or invasive margins. This is the gross appearance of this yellow thing is the adipose tissue, normal breast tissue. And this gray white area is irregular infiltrating carcinoma or the cancer, tumor part. So what are the risk factors? The risk factors: gender. The females are 100 times more predisposed to develop carcinoma, cancer, than the males. Males have a very small risk. Males also will develop breast carcinoma, but it is 1%. When there are 100 females developing breast carcinoma, among them, only one will be one male will be developing breast carcinoma. The age risk is once puberty menarche occurs. So gradually, as the age increases, the risk for breast carcinoma also increases. After the age of 50 years, around 75% of the breast carcinomas occur, and the peak incidence is around the 7th decade of life. So as the age increases, the risk for breast carcinoma increases. The peak incidence is in the 7th decade of life. The genetics, the genes, the BRCA1, BRCA2, BRCA1 and BRCA2 genes are mutated in breast carcinoma. These are the tumor suppressor genes. Tumor suppressor genes normally apply brakes to the cell cycle. When there is mutation in the tumor suppressor genes, the brakes are lost and the cells continue to divide perpetually. That will result in carcinoma. The family history. So the first degree relatives, when there is a history of breast carcinoma in the family, first degree relatives means mother, the sister, or children. So when there is a degree, when there is a family history of breast carcinoma, these individuals are 2 times more increased to develop breast carcinoma when compared with the general population. Personal history: if the person is having a breast carcinoma, if the surgery is done, but this person will have the possibility of developing a new carcinoma, not the recurrence. Freshly developing a new carcinoma is more likely in a person who has breast carcinoma. It may develop in the contralateral breast. Menstrual periods. So the longer the reproductive period, if the menarche is very early, if the menopause is late, so the longer the reproductive life, the more is the risk for developing breast carcinoma. Having children, more is the number of children, less is the likelihood of developing carcinoma. The first childbirth, early childbirth is a protective mechanism. A person who gives birth to children at 21 years is very much protected when compared to a person, when a woman who gives birth around 35 years of age. The late childbirth, late first childbirth is a risk factor for breast carcinoma. So birth control. So taking OC pills is not, it is not proven to be a predisposing factor, but the taking the estrogens for the osteoporosis after menopause, it is associated with the development of breast carcinoma. Breastfeeding is a protective factor for breast carcinoma. So risk factors, menstrual period. So women who develop periods early, before the age of 12 years, or who went into menopause after the age of 55 years, they have a slightly increased risk of developing breast cancer. Longer the reproductive period, more is the risk of developing breast carcinoma, because they are more exposed to estrogen, unopposed by progesterone. So the first degree family relatives, when there is a mother is having a breast carcinoma history, the children are twice more predisposed to develop breast carcinoma. Even then, 85% of breast carcinomas do not have the family history. That means if you are not having a family history, even then we may develop the breast carcinoma. So the first childbirth, the early first childbirth is a protective factor. The women who give birth to the first child after the 30 years or 35 years, they are more likely to develop breast carcinoma. Breastfeeding is a protective factor for breast carcinoma. So breastfeeding for more than 1.5 years or 2 years, it is a protective factor. Not only that, the milk which is given in the first 1 hour after birth is good. It is more amount of the colostrum. It has rich in immunoglobulins. It is a protective factor for the child as well. It is good nutrition for the child. So breastfeeding should be encouraged in all ways. It not only protects the mother against breast carcinoma, it also provides the nutritious growth factors and the immunoglobulins which are needed for the child. So breastfeeding should be encouraged by all means. So obesity and cancer. So the increased obesity increase the risk of all these carcinomas: esophagus, thyroid, colon cancer, kidney cancer in case of men. In case of women, esophagus, carcinoma, endometrium, gallbladder, and the kidney. These cancers are predisposed in case of obesity. So obesity, when the women are obese, there is a high levels of estrogen. So high estrogen levels, they predispose the development of endometrial carcinoma. But with breast carcinoma, we are not having data. The data is controversial in case of breast carcinoma. So obesity, there is increased risk of estrogens. Increased estrogen level is a predisposing factor for endometrial carcinoma. Breast carcinoma association with obesity is not clearly known. So these family history, when there is a family history, these individuals are 2 times likely to develop breast carcinoma. So the menarche, the reproductive life, when the reproductive age is more, they are more predisposed to develop breast carcinoma. The first live birth, early is the first live birth, less risk is there. But people giving birth to child at 30 years of age, they are at more risk. So there are also diseases. We'll see the disease later. So as the age increases, there is risk also increases, and prolonged exogenous estrogen postmenopausally for osteoporosis is a risk factor for breast carcinoma. Oral contraceptive pills, they do not show any association with breast carcinoma. Ionizing radiation of the chest. So for lymphoma is a malignant tumor of the lymphoreticular system. So for lymphomas, chest radiation is done. When they are exposed to chest irradiation, there is an increased risk for breast carcinoma. But for mammogram also there is exposure to the radiation, but it is of low dose. So there is no significant increase in the breast carcinoma for mammographic screening. So other less well-established risk factors are obesity, alcohol consumption, and diet high in animal fat. These are less well-established factors of breast carcinoma, risk factors. So the signs and symptoms. Whenever there is a dimpling on the skin, it is a risk fact. It is a suspicious sign. So when there is a lump especially in the outer, the breast is divided into 4 quadrants. So this is the outer and upper quadrant. So 70% of the lesions will occur in the outer and upper quadrant. Another 10% will occur just beneath the nipple. So this is the place where the carcinoma usually arise, outer and upper quadrant and beneath the nipple. And the remaining 20% is distributed in the remaining quadrants. Whenever there is a retraction of the nipple, when the nipple is pulled in, then it is a suspicious sign of breast carcinoma. Whenever there is a discharge, a bloody discharge from the nipple, it may be a breast carcinoma. Whenever there is a pedo orange appearance of the skin, whenever the skin over the breast appears like orange skin, that is also a risk factor for breast carcinoma. So here you can see the retraction of the nipple. It is a risk factor for breast carcinoma. This is an ulcerated lesion which has advanced, and this is a pedo orange appearance of the skin. The skin will appear like orange skin. This is due to infiltration of the dermal lymphatics. So that will give a pedo orange appearance of the skin. Here also there is a retraction of the nipple, and this is the inflammation over there in a carcinomatous carcinoma. The entire breast is highly hyperemic. The blood vessels are dilated. And this is a male breast carcinoma. Very rare. Very rarely we see a male breast carcinoma. So why does the cancer cells move to the other places? So the cancer cells, normally the cells are glued to one another by adhesion molecules. But when the cancer develops, there is a gradual loss of the adhesion molecules. So the tumor cells are free. There is a loss of the adhesion molecule. Adhesion molecules will help in binding the tumor cells to one another. But in tumor cells, there is a decreased expression or loss of expression of the adhesion molecules. So the tumor cells are free. And the tumor cells will secrete some factors, autocrine motility factors, which will help the tumor cells to move towards the blood vessels. So the tumor cells will gradually move towards the blood vessel, and they will also secrete some enzymes which will digest the basal membrane of the blood vessel, and they enter into the blood vessel. And once they enter into the blood vessel, they will move to a distant place. And when they find a comfortable place, there they start forming. Usually they start forming in a lymph node. Then they form another colony. So this is a basis why the cancer cells move from one place to another, means this is the explanation. There is loss of adhesion molecules. There is secretion of some autocrine motility factors. They will produce also some digestive enzymes which will digest the basal membrane. And these tumor cells will enter into the vasculature. It can be either lymphatics or even the blood vessels. And then they move to a comfortable place where they colonize and develop another tumor. So this is the basis of why the tumor cells will spread, means this is the exam. This is the explanation. So whenever there is a lump in a breast, these are the possibilities. But only 10% of the lumps turn out to be cancer. 30% there is no disease. It may be some clotted milk. So 30% of the cases lumps, it is not a disease. It may be a galactosile or the milk may clot. So around 40% there is a fibrosis or there is a cyst formation. Just aspiration will completely cure the, we put a needle, draw the fluid completely. That's the treatment. 40% of the swellings are cystic changes, fibrocystic changes. Fibroadenoma is a benign tumor. It is not a it is not cancerous. Around 7% of the lumps are fibroadenomas. So out of the 100, only 10% of the lumps are carcinomas, cancers. So what is the clinical course? Usually the patient itself discovers there is a solitary, a single, painless. The problem with the carcinoma is it is painless. A cancer is a painless. When there is a pain, they will immediately seek the doctor. But since it is a painless, they will just ignore. So it is a painless solitary mass. Initially, it is mobile, but as the cancer spreads, as the size increases 2 to 3 centimeters, when it increases in size, it will firmly adherent to the underlying muscle or to the overlying skin. And in around 50% of the cases, by the time they reach the doctor, it has spread to the regional lymph nodes. So by the time they reach the doctor, it has been late. So even before the tumor is palpable, mammographic screening will help in diagnosis of breast cancer. So mammographic screening will help in diagnosis in the foremost stage where we can save the patient. So in some cases, the breasts are very dense. Mammography will help in differentiating the tumor by basing on the density of the breast. The adipose part is very less dense, whereas the tumor is more dense. But if the breast were very young patients, the breast is dense. So in case of dense breast, we have to go for MRI scanning, where we can pick up the tumors. It is an adjuvant. It is an adjuvant to the mammography. So the breast cancer spreads by the lymphatics and the hematogenous route, but the blood on the lymphatics. So the lymph nodes, the axillary lymph nodes are the first involved. These are called the sentinel lymph nodes. Then they spread to the other parts. So distant spread is called metastasis. Distant spread occurs to the lungs, liver, even to the bones and even to the brain. Any organ, it can spread. The distant spread means metastasis is the distant spread. Initially, the tumor spreads to the regional lymph nodes, and then it through the blood, it can spread to the lungs or the liver, to the brain, and even to the bones. So this is the staging of the breast carcinoma. So stage 0 means DCIS, ductal carcinoma in situ. When the tumor cells are confined to the duct only, if we do the lumpectomy, the prognosis is excellent. The 5-year survival rate in a case of ductal carcinoma in situ is 100%. Stage 1 carcinoma means the tumor is, it has passed beyond the basement membrane, but the tumor is less than 1 inch in diameter. The tumor is less than 1 inch in diameter. Here also the prognosis is very good. When we do the lumpectomy, 98% survive more than 5 years. The 5-year survival rate is more than 98%. So stage 1 means here the tumor is less than 2 inches, but it has spread to the axillary lymph nodes. That is stage 2. So here also, when we do the mastectomy with the axillary lymph node dissection, the survival rate is 5-year survival rate is 88%. Stage 3 means the tumor is greater than 2 inches. It has spread to the axillary lymph nodes, and it has also involved the skin. Then it is called stage 3. The 5-year survival rate is 52%. When in stage 4 means the tumor is more than 2 inches in diameter and it has spread to the liver, to the lungs. When there is distant metastasis, it's stage 4, and the prognosis is very bad. The 5-year survival rate is less than 16%. So what are the investigations we do when we get a breast carcinoma? Mammogram. This is the best modality for the diagnosis of breast carcinoma. Mammogram will pick up the breast carcinoma even before the lump becomes palpable. In case of dense breast, MRI, magnetic resonance imaging, is needed. It will be an adjuvant to the mammogram. So usually when we get a breast carcinoma, the clinician will send the patient to the pathologist, where the pathologist will put a needle into the lump, aspirate the cells, put them on the slide, and examine under the microscope. So under the microscope, we can diagnose the breast carcinoma. The pathologist's duty is to identify the tumor cells by viewing under the microscope. So we aspirate the tumor cells, we'll put out on the slide and examine under the microscope. So that is FNAC, fine needle aspiration cytology, or breast biopsy is done to diagnose the tumor, breast carcinoma. So the treatment, so multimodality treatment is done. Usually the main modality is surgery. Whenever there is a lump in the breast, except for the cyst, the only in case of cyst, aspiration will do. But whenever there is a fibroadenoma or carcinoma, whenever there is a tumor in the breast, it should be excised. There is no other treatment. Surgery followed by chemotherapy or radiotherapy, basing on the situation. If it has spread to other parts of the body, then chemotherapy is to be done. If the tumor is not accessible to surgery, the radiotherapy is given. Hormonal therapy, if the tumor cells are expressing estrogen and progesterone receptors, then hormonal therapy is good. So the mainstay for the treatment is always breast carcinoma is lumpectomy or mastectomy. Lumpectomy means the tumor is removed along with the wide margins, along with the nearby margins. Mastectomy means the entire breast along with the skin is removed, and also radical mastectomy means also the lymph nodes are also removed. So lumpectomy, mastectomy is the treatment of choice in case of carcinoma of breast. So chemotherapy is done when the tumor cells are spread to other parts of the body. Then the chemotherapy drug is given, and this chemotherapy will inhibit the division of the tumor cells. It will also kill the tumor cells. Chemotherapy. For radiotherapy, high dose energy is given to the tumor cells, and the cancer cells are killed by radiotherapy. So hormonal therapy. Whenever we get breast carcinoma, after doing the surgery, the tissue is sent for the ER and PR. ER means estrogen receptor. PR means progesterone receptors. ER and PR status is done on the tissue which is sent to the pathologist. So if there is ER and PR positivity, the prognosis is very good. ER, PR positivity means we will give anti-estrogens. Tamoxifen is given. So when the tamoxifen is given, it will, these tumor cells, they are not supported. The ER and PR tumor cells, they need estrogen and progesterone. When tamoxifen is given, the estrogen and progesterone are withdrawn. So these tumor cells will die. So prevention of breast carcinoma is by control of weight, and at least half an hour for in a 5 day, in a week, in a 7 days, at least for half an hour for 5 days, that exercise will do, that physical activity. So breastfeeding, early breastfeeding will help in breastfeeding for 1.5 to 2 years. That is a protective factor against breast carcinoma. A healthy diet. We'll see what is a healthy diet. And hormonal therapy, discontinue hormonal therapy. So post-menopausal women, they are given estrogens to prevent osteoporosis. So osteoporosis, estrogen has been implicated, post-menopausal estrogen therapy has been implicated in breast carcinoma. So that should be discontinued. Avoid exposure to environmental pollution. So prevention is by preventing obesity, regular exercise for half an hour for 5 days a week. Stop the hormone replacement therapy. Alcohol is a risk factor. Consuming alcohol is a risk factor. Breastfeeding is a protective factor. Not having children is a risk factor. So screening is done by mammogram, the clinical breast examination, and the breast self-examination. These are the modalities of screening. So when between the 20 and 40 years of age, at least every 3 years, the women should consult a doctor and get their breast examined. After 40 years, every year it should be followed. The clinician will just palpate the breast, and if there is any risk, they will ask for FNAC or mammogram. So after 40 years, every year, annually, the breast examination should be done by the clinician. Breast self-examination should be done. They should be examined. So you should examine even under the arms, and you may discover any changes. If there is any asymmetry in the breast, if there is one nipple is higher or lower, if there is a retraction of the nipple, if there is a skin change, then you should consult a doctor and get it cleared. So what are the prognostic factors of breast carcinoma? The tumors invasion, the size. So when the size, in situ carcinoma, when it is in situ, if the lump is removed, the prognosis is very good. If the tumor is less than 2 centimeters, the survival rate after lumpectomy is 5-year survival rate after lumpectomy is 87%. Extent of lymph node. When there is no lymph node involvement, the survival is very good. But when there is more than 4 lymph nodes are involved, then the prognosis is bad. So the prognosis is inversely proportional to the number of lymph nodes. More the number of lymph nodes involved, less is the survival chances. Distant metastasis. When the cancer has spread to the other parts of the body, the prognosis is very bad. When there is distant metastasis, the 5-year survival rate is 15%. Out of 100 patients, only 15%, 15 people will survive more than 5 years after mastectomy and chemotherapy. In case of stage 4. So histologic grading. Well-differentiated carcinomas, they have better prognosis. Poorly differentiated carcinomas have poor prognosis. So histologic type. Normally, the type of carcinoma is infiltrating ductal carcinoma. But these histologic types, tubular carcinoma, medullary carcinoma, mucinous carcinoma, these are the histologic types. These have a better prognosis than the normal infiltrating ductal carcinoma. 70% of the carcinomas are ductal carcinomas. These are the tubular, medullary, and mucinous carcinomas. They are the special types. They have a better prognosis when compared with the ductal carcinomas. So estrogen and progesterone receptors. So after mastectomy, the ER and PR status is done. IHC, immunohistochemistry, is done to know the ER and PR, estrogen receptor and progesterone receptors. These tumor cells need estrogen and progesterone to proliferate and to survive. So when there is ER and PR positivity, we give anti-estrogens. So on giving anti-estrogens, all the tumor cells are killed and the prognosis is very good. Nearly 80% of the people will survive more than 5 years. But when both are negative, if ER and PR both are absent, they don't respond. The prognosis is very bad. ER and PR negative means it is going to be a very bad prognosis. So how to interpret the histopathology report? So most of the times we will give the fibrosis after doing FNAC or after specimen of the breast is given. We will give the diagnosis as fibrosis or cystic change or apocrine metaplasia. These things do not carry any risk of carcinoma. They are benign. They won't. There is no risk. But whenever there is a florid hyperplasia, whenever there is a papillomatosis or sclerosing adenosis, if this report is given, there is a slightly increased risk. Without hyperplasia or papillomatosis or sclerosing adenosis, this histology report means there is a slightly increased risk. Significant increased risk, atypical hyperplasia, that is a significant increase, 5-fold increased risk of developing breast carcinoma. So how to interpret the BI-RADS? So when we get the FNAC, usually the pathologist will receive we'll get the patients for any swelling in the breast. So this report is there, BI-RADS 4, BI-RADS 6. So often we confuse what is this BI-RADS 2, 3. So when they say BI-RADS 0, BI-RADS 0 means the interpretation is not possible. Another repeat scan is needed. Either MRI scan is needed to interpret. BI-RADS 1, this is the radiologist diagnosis. If BI-RADS 1 is given, yes.
Sorry, sir, the meeting is about to be over in a minute. So can we rejoin before we explain the BI-RADS category?
Okay, done.
Guys, we'll rejoin the same link.
Okay.
Yes, sir.
సో మళ్ళీ ముందుకు వెళ్ళాలైతే
లేదు సార్